So the next presentation will be presented by Dr. Boychev, and the topic is critical visceral ischemia.
Which is best? Okay. Regarding the initial author was Dr. Petrov, but unfortunately he's abroad, so he couldn't make it. And I'm Damian Boychev from the cardiology clinic at Sofia Med. So we are going to present you a case of a young male, and it's a bit backwards. First the case, then the discussion of a pretty young male, 55 years old man with postprandial abdominal pain for the last 6 months, loss of weight, 15 kilos in the past 6 months, and intermittent vomiting for the same period. He's unknown guy with atherosclerotic disease, severe atherosclerotic disease of the lower limbs, with diabetes, with arterial hypertension, the typical profile of such patient. So how he got and why he was at cardiology is a hard question, but yeah, he was at our department. Overall, from the status, he had mildly impaired overall condition. For a guy who lost 15 kilos in the last 6 months, it's pretty normal, and postprandial pain with lower limbs with reduced AB indexes on both legs, more for the left one. So from the lab results, we had a pretty increased creatinine levels for a 55 years old man. This was thanks mainly on the diabetic nephropathy and lots of peripheral interventions in the past, normal hemoglobin levels, normal liver levels, a bit low albumin. So this is first what we considered. He had some ambulatory exams with the gastroenterologist, and he was referred for additional exams in hospital, which he hasn't done. What we proceeded, we thought about mesenteric ischemia initially, and we did a native CT scan because of the high creatinine levels, and from the native CT scan you can see 2 big calcified nodules in the celiac artery and in the superior mesenteric artery. Then we proceeded with here you can see both of them. The one in the superior mesenteric artery is even protruding in the aorta. And we continued with contrast CT angiography, and you can see the CT angiography. Here it's, I'm sorry for the pictures and the videos, but I didn't have time to prepare better ones. So here you can see how the mesenteric arteries are. On the right you can see the occlusion of the superior mesenteric artery, and we consider to try and revascularize the superior mesenteric artery. We proceeded with angiography with the right brachial index. This was the preferred approach because as you all know, they have caudal exit the mesenteric and the celiac arteries, and it's better to use upper extremities approach. Some of the centers even have the preferred approach is left brachial. On the right, let me see, on the right you can see the calcified nodules even on the still angio. So here on unselective puff you cannot see the superior mesenteric artery, neither the celiac trunk. This is just the renal artery, the left renal artery. Also because, yeah, I forgot that, he also had inappropriate lower limbs approaches. So we tried, to be honest, at the beginning we were pretty skeptical about our future success. But with V18 guide wire, the occlusion was crossed, and it was crossed rather not easy, but less hard than we expected to be. With all the telescoping techniques I have mentioned, with 6 French right Judkins, 5 French inside of it, and a trailblazer catheter. When we crossed the occlusion with the V18 guide wire, the guide wire was exchanged with 2 coronary wires. And then coronary non-compliant balloon was placed, and then several inflations at high atmosphere. The artery was open. Here you can see, yeah, it's not a sufficient result, but it's still open. And then we proceeded with stenting of the artery. We implanted a peripheral stent, the OmniLink stent, initially at 8 atmospheres, and then we had several long inflations at higher atmospheres, but still persistent waste, which was not a surprise considering the high calcified nodule in the high calcified volume. So during the inflations, he also, inflations multiple, maybe for 10 minutes, multiple inflations, he started having severe abdominal pain at rest. So we decided to see what's the final result, and we consider it as sufficient at this moment, because first we had already advanced with around 150 milligrams of contrast. And also here we can see that due to the celiac truncus is supplied through collaterals, and as we know, in those cases, the preferred route when we have occluded or high stenotic celiac artery and superior mesenteric, the preferred protocol is to use to try to revascularize the superior mesenteric, then to assess the collateral blood supply. And in this case, we were happy with the result at this moment. So we decided to stop the procedure. In the follow-up, during the stay in the hospital, just a small hematoma on the puncture site, which is pretty common for a brachial approach, nothing requiring surgery or whatever. The creatinine levels stayed pretty much the same, so no worries regarding that. Then we had, you asked about follow-up. The patient was referred for control CT angio after 1 month, for which he didn't come, but he came back for acute myocardial infarction 8 months later. And after the procedure was done, we decided to see how the artery is doing. The patient had gained some weight, which was a pretty good sign initially, but yet again, on the angio on the right, you can see that the artery is fully patent. Unfortunately, it was the old angio machine, and the subtraction was not working at this moment, and afterwards it was replaced. So, as I said, it's backwards, the presentation. Last year, the European Society of Cardiology, together with the European Society of Vascular Medicine, published a very, very huge, we all know the huge guideline of peripheral artery disease and aortic diseases, and pretty much every vascular territory is mentioned in this guideline, but unfortunately not very big detail for some of them. And of course, the mesenteric artery is not covered with much recommendations. As you can see here, the recommendations for the in patients in which we have some type of ischemia, mesenteric ischemia, or at least we have a suspicion of such, the preferred technique, first technique of imaging is CT angiography. And then if any type of procedure is preferred, the endovascular devascularization is recommended as a first line of therapy. To be honest, in this particular guideline, the 3 mentioned studies are from 2017 to 2019. And later on in the European Society of Vascular Surgery was published also a big single center experience, but with more than 400 patients, which mentioned that the open surgery approach for acute mesenteric ischemia for them was better. And they showed that doing an open approach first led to lower gut resection volume. But yeah, it is not mentioned here. So, and also in patients with acute or mostly for chronic and asymptomatic patients, there is for sure a multidisciplinary discussion ahead that should be done. For acute, of course, the time is a problem. And then I found out a European guideline on chronic mesenteric ischemia, which was published by 6 or 7 different societies, societies hepatogastroenterology, gastroenterology, vascular surgery, and radiology societies, and stuff like this. And yeah, it was actually a lot longer than our guideline, and the recommendations were a lot more. I have just add some of them. Here, yet again, the first step of diagnostic is CT angiography. This is the gold standard. Here it's the class 1C recommendation. And then we go back to the revascularization purposes. For patients who are asymptomatic, it is not recommended to do revascularization. It should be a multidisciplinary discussion, but a routine revascularization is definitely not recommended. Again, the preferred entry site for endovascular revascularization is femoral arteries, radial, brachial arteries, but the first are brachial and radial, so the upper limbs. Also, in these cases, it's preferred the patient to be stented. PTA with just balloon angioplasty is not the preferred option. Regarding the antiplatelet therapy, is the same as Dr. Dubrichkov said. In patients with anticoagulation recommendations, they should be left on anticoagulant, and for other patients, dual antiplatelet for a month and then followed up by mono antiplatelet therapy. Something else which I may have missed. Yeah, here yet again the preferred recommendation, but in the European cardiology guideline it was with class 1B. Here it's 2C grade of recommendation, the first to be endovascular and then the surgery. It's written down maybe some way of backwards, if yeah, the recommendation number 16. So mesenteric bypass procedure might be reserved for patients in whom endovascular is not suitable. So I guess this should be read as endovascular first. And yeah, as a conclusion, visceral ischemia is definitely a life-threatening condition. Chronic one, yeah, it takes some time, but in acute one, as Dr. Dubrichkov said, definitely a very, very scary condition. And multidisciplinary discussion plays a major role in taking the right decision for the patient. And also interventional treatments definitely have a place for these patients. Thank you.
Thank you very much for a nice presentation. I have a few comments. First of all, now having some experience, we kind of violating a little bit the recommendation, because sometimes we are treating, how to say, not severely symptomatic cases when we have 2 or 3 vessel disease, because it's quite simply to stent the stenosis and very tricky to cross the occlusion, as you are lucky in your case, so congratulations. Yeah. And just sometimes this chunk of calciums makes you think about kind of a lithotripsy, intravascular or something, just to be able to open up the stent. And what is the second remark is, in a case like this, a few times we have seen relatively well-developed reperfusion syndrome. Because sometimes these guys have some symptoms and swelling, distension after the revascularization, and if you put your transducer straight after, you may see a lot of vessels coming up, which were not there before. Sometimes you need to treat these guys for a couple of days in the hospital, but otherwise it's life-saving. Yeah,
he was left for 3 days. I think it was even mentioned in the text that he had some complaints, gastrointestinal complaints in the first few days in the hospital, but then everything passed away. And also regarding the next steps on the pre-procedure discussion, the first step was to try a superior mesenteric artery, then celiac artery, and even in the discussion, but this was in the field of colleagues from the vascular surgery, was open surgery. And also in the recommendations is mentioned everywhere the retrograde stenting of the mesenteric artery, but it's not in the field of cardiology, definitely.
I even think that some clever intervention cardiologists can propose like a bariatric procedure, just kind of a closure of the mesenteric artery, because the effect is very pronounced. But yeah. So any other questions from the audience?
Yeah, I would like to ask, in such cases with severe calcium stenosis, do you consider cover stenting, or do you use, I mean, I'm pretty sure we don't use lithotripsy, unfortunately, we don't have in our house.
We know how it goes with lithotripsy.
Yeah, but how about cover stents to prevent, I mean, even in case of eventual rupture due to the calcium, to prevent abdominal bleeding?
Yeah, it's definitely have a place in it's there in the discussion, but we don't have so many patients to have a strict protocol, so it's definitely case by case.
Yeah. Thank you.
Thank you.
Okay.